Hi, we are Paul Didden and Veronique van der Voort, working at the Gastroenterology Department at the University Medical Center Utrecht in the Netherlands. On behalf of my co-authors, I would like to thank Endoscopy for this opportunity, and we would like to introduce our article entitled Efficacy and Safety of Cap-Assisted EMR for Treatment of Non-Lifting Colorectal Polyps.
Endoscopic mucosal resection, also known as EMR, is the preferred treatment for benign, large, non-pedunculated colorectal polyps. However, non-lifting due to submucosal fibrosis is one of the most important reasons for incomplete resection and is associated with recurrence and adverse events. Although different endoscopic techniques have been shown to be helpful in eradicating non-lifting polyp tissue, it is still considered a challenging problem for endoscopists. Cap-assisted EMR is a simple, well-known, modified EMR technique which may also allow to capture fibrotic polyp tissue in the snare.
This is the first study to evaluate the efficacy and safety of cap-assisted EMR for benign non-lifting colorectal polyps. In this multi-center study, we prospectively registered all cap-assisted EMR procedures for presumed benign non-lifting colorectal polyps. We included 70 lesions with a median size of 25 millimeters and a median size of the non-lifting target area of 15 millimeters. In the majority of the polyps, non-lifting was caused by previous attempts of endoscopic resection.
Complete polyp removal was achieved in almost all patients, reaching a technical success percentage of 97.1%. Of these cases, 67.1% were successfully treated with cap-assisted EMR alone, and adjunctive treatment was performed in the remaining 21 patients. Adjuvant therapy was applied in nearly all patients, including ablation of the margin and/or the fibrotic resection site.
Overall, 66 polyps showed benign histology, and the endoscopic follow-up after a median of 6 months showed recurrence in 19.7%. All benign recurrences were treated endoscopically. Deep mural injury type 3 to 5, according to the Sydney classification, occurred in 7.4% and were all treated successfully with clips.
In conclusion, we demonstrated that by incorporating cap-assisted EMR in the management of relatively large fibrotic areas, complete removal can be accomplished in more than 2/3 of patients with cap-assisted EMR alone, and in nearly all patients when also applying adjunctive treatment.
We believe that advantages of this technique are its capability of excising larger pieces with the potential of achieving a complete resection with less fragmentation. Furthermore, it is a simple modification of standard EMR without requiring additional instruments or advanced skills.
However, we still encountered recurrent adenoma in some cases during follow-up, all treated by repeated endoscopic therapy. Although we have introduced a new attractive option for a tricky problem, further studies comparing different approaches are needed to determine how to handle this problem most effectively. Thank you for your attention.